Hello everyone, this is the EMT 200 overview of brain, head, and spinal trauma. So we're going to talk about injuries to the brain and spinal cord, assessment findings, and management. So with the nervous system, is a complex network of nerve cells. It includes the brain, spinal cord, and several billion nerve fibers. And it's well protected. It's protected by the skull. The brain's protected by the skull. The spinal cord has the spinal canal. And when these do occur, the injuries can be devastating. So the nervous system has two anatomic parts, the central nervous system and the peripheral nervous system. The central nervous system includes the brain and spinal cord. And this controls the body and is the center of consciousness. And it has three major parts, the cerebrum, cerebellum, and brainstem. The cerebrum controls a variety of activities and voluntary motor function, conscious thought. It has about 75% of the brain's total volume. It has two hemispheres and four lobes. The cerebellum controls balance and movement, and the brainstem is the best protected part, and it controls functions necessary for life. The spinal cord is made up of fibers that extend from the brain's nerve cells, and these carry messages between the brain and the body via the gray and white matter of the spinal cord. The gray matter is composed of neural cell bodies and synapses, and the white matter consists of fiber pathways. The central nervous system has protective coverings. The entire central nervous system, from the brain to the tip of the spine, is bathed in cerebral spinal fluid. The central nervous system has protective coverings, and it's covered with the skull and the spinal canal, and these usually withstand injuries. The central nervous system is protected by the meninges, which are three layers of tissue. The outer layer is the dura mater, the tough fibrous layer. The inner two layers are the arachnoid membrane and the arachnoid mater and the pia mater, and these contain blood vessels, and these blood vessels can become destructive and cause bleeding. Cerebrospinal fluid is produced in the chamber inside the brain, the third ventricle, and this is between 125 and 100 milliliters of cerebrospinal fluid in the brain at any one time. And this has the shock absorber. When an injury does penetrate the protective layers, clear cerebrospinal fluid may leak from the nose, ear, or from an open skull fracture. In the peripheral nervous system, there's 31 pairs of spinal nerves. These conduct impulses from the skin and other organs to the spinal cord. These conduct motor impulses from the spinal cord to the muscles. Spinal nerves serving the extremities are arranged in a complex network. 12 pairs of cranial nerves. These transmit information directly to or from the brain. These perform special functions in the head and face. And these sight, smell, taste, hearing, and facial expressions we think from our cranial nerve exam. And there are two types of peripheral nerves. The sensory nerves carry only one type of information from the body to the brain via the spinal cord. In motor nerves, there's one for each muscle, and these carry information from the central nervous system to the muscles. And then connecting nerves are only found in the brain and spinal cord. Connect sensory and motor nerves with short fibers, and these allow for the exchange of simple messages. So the nervous system controls all the body's activities, including reflex, voluntary, and involuntary. And connecting nerves in the spinal cord form a reflex arc. So if a sensory nerve is in this arc detects something irritating, it bypasses the brain and sends the message directly to the motor nerve. So if you think of the hot stove, as soon as that sensation hits the spinal cord, it does not even reach it to your brain before you realize what you're doing when you pull it away. So voluntary activities are things that we perform, where sensory input determines the specific muscle activity. Involuntary actions are not under conscious control, so I think of breathing as the most common example of that. And somatic nerves handle the voluntary actions that the brain interprets sensory information that it receives from the peripheral and cranial nerves and sends signals to the voluntary muscles. The autonomic nervous system handles bodily functions. These are divided into two sections. We've been over this before: sympathetic and parasympathetic. Sympathetic nervous system is the fight or flight response. When confronted with a threatening situation, the sympathetic nervous system reacts to the stress with increased heart rate, dilated pupils, dilated lower airways, increased heart rate and blood pressure. And during stress, hormone epinephrine is released. The parasympathetic nervous system has the opposite effect. Blood vessels dilate, causes the heart rate to slow. Relaxes the muscle sphincters as the body attempts to maintain homeostasis. These two divisions of the autonomic nervous system tend to balance each other out as basic body functions remain effective and stable. So the skull. The skull has two groups of bones, the thick cranium and the thick shell above the eyes that protects the brain. The cranium is composed of 80% of it brain tissue, 10% blood, and 10% of cerebrospinal fluid. There are four major bones that make up the crania: the occiput, temple, parietal region, and frontal region. And this is important for documentation and for reporting injury findings. And there's 14 bones in the face: the maxilla, zygomas, mandible, and orbit. So the maxilla is a non-movable jawbone. Zygoma is the cheekbone. Mandible is the lower movable portion of the jaw, and the orbit is the eye socket. And the nose has flexible cartilage. Along the spinal column, the body's central supporting structure, there's 33 vertebrae. There's the cervical at the top, thoracic, lumbar, sacral, and coccygeal. There's 7 cervical vertebrae, 12 thoracic vertebrae, 5 lumbar, 5 sacral, and 4 coccyx. So injury to the vertebrae can cause paralysis, and these are connected by ligaments separated by cushions called intervertebral discs. And the spinal column is almost entirely surrounded by muscles. So for head injuries, trauma is an insult to the head, may cause soft tissue, bony structures, injuries of soft tissues, bony structures of the brain. Closed injuries, where the head is injured but there is no opening into the brain. Open injuries, and these are less common. There's an opening to the brain from the brain to the outside world, and this is usually from penetrating trauma. There may be bleeding and exposed brain tissue. So scalp lacerations can cause significant blood loss. These can be severe enough to cause hypovolemic shock. They're often a sign of a more deeper injuries. So think about what caused the skull for the laceration, and think about how it may have affected the head. So with the skull fracture, there must be significant force applied, and these can be open or closed, and these are often from bullets or penetrating weapons. So when there's a skull fracture, the signs include the patient's head may be deformed, there's visible cracks in the skull. Ecchymosis or bruising develops under the eyes, and that's called raccoon eyes, and it develops behind one ear over the mastoid process. That's battle sign. And these are late findings. These you probably will not see them during the emergencies, in an emergency situation. There are linear skull fractures. 80% of skull fractures are linear. And they're non-displaced. So if you palpated the head, it would not move. And you need to find, this is picked up on X-ray. Okay, so depressed skull fractures, this is high energy trauma with a blunt object. And the frontal and the parietal bones are most susceptible. Bony fragments can drive into the brain, which causes injury. And patients will usually present with a neurologic sign, at least a loss of consciousness. Basilar skull fractures are all associated with even higher energy, and these usually occur during a diffuse impact to the skull, so fall or crash. And then this is an extension of the linear fracture to the base of the skull, and these also need to be diagnosed on X-ray, but these will cause CSF drainage in raccoon's eye. Okay, open skull fractures occur when there's an opening between the brain and the environment. And these have a very high mortality rate. And brain tissue increases the risk of not only whatever the injury is to begin with, but also infection. So traumatic brain injuries. So these are an insult to the brain capable of producing physical, intellectual, or emotional, social, or vocational changes. And there are two broad categories, primary and secondary. So primary results directly from the impact of the head. And secondary, it increases the severity of the primary injury. So there's continued swelling or hypoxia. There might be hypotension if the brainstem's damaged, cerebral edema, or an infection. So hypoxia and hypotension are the two most common causes of secondary injury. And then this can for a few minutes to a few days. So the biggest role for EMS is to limit the secondary injury. And this is by managing the airway and managing intracranial pressure and hypoxia. So some indirect traumatic brain injuries, you talked about the coup, counter-coup injury. This is the front, the brain, the cerebrum strikes the front part of the skull, and then the opposite end of the brain bounces back and affects the other skull. So the head may fall back against a headrest or seat. This causes cerebral edema, which may not develop until several hours later. And then low blood oxygen levels aggregate the edema and make it even worse. You may see a seizure in patients with this. So with intracranial pressure, accumulation of blood within the skull squeezes the brain against the bony prominences in the cranium. And with this increasing intracranial pressure, those see Shane-Stokes respirations, which is a pattern of increasing followed by slow respirations and even periods of apnea, and ataxic or buyout respirations, which is an irregular respiratory pattern that has no cycle to it. So a decreased pulse rate, headache, nausea, vomiting, altered mental status, and bradycardia, sluggish pupils, and posturing are all signs of increasing intracranial pressure. And this can be caused by intracranial bleeding, which causes increased intracranial pressure. And this can be between the skull and the dura mater, subdural hematoma, beneath the dura mater but outside the brain, so subdural, and then within the tissues of the brain itself, so that would be an intracranial hemorrhage. So an epidural hematoma is between the skull and the dura mater, and this is usually a linear fracture around the artery in the temporal area. And these are rapid progression of symptoms. The patient may lose consciousness, and then they may have a brief period of consciousness or elusive interval, and then they lapse back into unconsciousness. So that's the epidural hematoma. The lucid interval is the hematoma. And the subdural is the accumulation of blood beneath the dura mater, but outside the brain. And these, usually there's strong deceleration forces. And there may or may not be a skull fracture with this. And this is usually associated with the venous bleeding. So the symptoms can develop more gradually. The patient may have a fluctuating or changing level of consciousness and slurred speech. And an intracranial hemorrhage, this is bleeding within the brain tissue, and this can be from a blunt or penetrating trauma, or there are medical causes as well. And these also have a high mortality rate. The subarachnoid hemorrhage occurs when blood goes into the subarachnoid space where the CFS circulates. And this causes signs of meningeal irritation. So this is the sudden severe headache. This also could be a ruptured aneurysm. So a concussion, you use this in the news a lot right now. So there's a blow to the head or face. This is a closed injury with a temporary loss or alteration in part or all of the brain's ability to function without physical damage to the brain. And by physical damage, it means that if you did a CAT scan, you would not see any damage from the concussion, but there is a temporary loss or alteration of functioning. And then 90% of patients do not experience a loss of consciousness. So they just because they report a loss, just because they didn't lose consciousness, doesn't mean that they did not have a concussion. Any change in mentation is a sign of a concussion. They may be confused or have amnesia. A lot of times patients with concussion will have repetitive questions. And usually it only lasts a few times. So patients may have dizziness, weakness, visual changes, nausea, vomiting, ringing in the ears, slurred speech, or have difficulty focusing. And they may have lack of coordination or motor function or be disoriented. So we don't know. A concussion is diagnosed in the hospital, especially shortly after the injury. This is always a diagnosis of exclusion, and the patients need to be evaluated in the hospital. What is more serious is the contusion, and this does involve physical damage to the brain, and there's maybe long-lasting or permanent damage. So, and this is actually a bruise to the brain where the skull is struck. So spinal injuries, so compression injuries can result from a fall. Forces that compress the patient's vertebral body can cause herniation of discs. So motor vehicle crashes can overextend the spine. Compression can result of a fall regardless of the surface that the patient landed on. Forces compress the spine as move up the spine. Rotational flexion injuries spine can cause from rapid acceleration forces. And this is most likely to happen to C1 and C2. And these areas of the spine are considered unstable because they lack the bony prominence and soft tissue support. So when the spine is pulled along this length or hyperextension, that can cause fractures. And any one of these national motions, as well as excessive bending or lifting, can result in fractures. And when bones of the spine are altered from traumatic forces, they can fracture or move out of place. And when they move out of space, damage to the spinal cord can occur. So you may have pain or tenderness on palpation of the spine. You may feel a deformity, what's called as a step-off. The spinous process may be palpable. If you suspect this type of injuries, then that's the patient we would do spinal immobilization on. So, who do we think has a spinal injury? Well, anyone in a motor vehicle crash, pedestrian motor vehicle crash, fall from a standing height, anyone with trauma to the head, neck, or back, we're going to presume that they have a spinal injury. We're going to suspect this possible head or spinal injury with a rapid deceleration injury, hanging axial load versus like falling and landing on the feet, or diving accidents. So during our primary assessment of trauma patients, we need to consider immobilizing the spine. And so we're going to start our assessment by we want to reduce any unnecessary movement. We want to assess the patient where they're found. Eventually, when we do the secondary assessment, we will consider placing a cervical collar. And if we're considering not clearing, if we want to clear the spine and not apply spinal motion restriction, we have to make sure the patient has good judgment, that they don't have any neurologic deficits, they're not intoxicated or any illness, because this can all mask spinal injuries. Okay, so the backboard again, which is not used around here anymore for this purpose, it can compromise circulation to the skin. Some patients it makes it more difficult to breathe. But what is used still is the cervical collar, and this helps maintain spinal motion restriction, but not as much as the backboard does. And once the cervical collar is on, we're going to leave it in place. So when we're assessing for a spinal injury, we want to ask about neck or back pain. If they have confused or slurred speech, they're not going to reliably answer those questions. We want to know what happened, where does it hurt, can you move your hands and feet, and did you hit your head? If the patient's unresponsive, we're going to assume that they have a spinal injury, and we're going to use the jaw thrust maneuver to open their airway. If the jaw thrust maneuver doesn't work, though, then we need to use head tilt chin lift. We want to be aware of vomiting, so if the patient is on a backboard, we would want to roll them on their side. So they are, and patients with high head injuries are at higher risk for vomiting. We're going to give oxygen to patients with head and spinal injuries. Even a small period of hypoxia is harmful for the brain. If we have to ventilate with a bag valve mask, if the patient has one of the irregular respiratory patterns, we want to make sure we avoid hyperventilation. So we want to keep the respiratory rate at 10 to 12 breaths per minute. But if a patient is having signs of herniation, and herniation is when the brain is actually being pushed out of the foramen magnum and into the spinal column, and that's usually a sign they'll have a patient will have a one dilated pupil. Then there may be some benefit to hyperventilation, which would be between 20 and 24 breaths per minute. But for the most part, you want to keep there's more harm from hyperventilation than for most patients will be harmed by hyperventilation. There's just a small segment that it may help. One thing, so if the patient has A head injury generally will not cause signs of shock. If the patient is in shock, suspect that there's another injury in addition to the head injury. But even one episode of hypoperfusion in a patient with a brain injury can significantly increases the risk of death and a poor outcome. So with head injured patients, we want to transport to a level 1 trauma center if we can, the highest level of local available trauma center, and consider using the helicopter. Whenever we're taking history, we want to know if the patient lost consciousness. We want to ask how long. We want to maybe use bystanders for that. We want to do a rapid head-to-toe exam. Initially, the 60 to 90 second rapid head-to-toe exam. And then we'll do a more detailed one if time allows on the way to the hospital. So with vital signs, the patient may have pulse may be slow, and they may be hypertensive. If the patient has a spinal injury, they may be in neurogenic shock, so they may be hypotensive from that. So when we're doing a neurological exam, we're going to compute a Glasgow Coma Scale. We want to assess the patient's speech, see if it's clear, if they answer questions in a logical manner, if they're able to make decision, and they wear their location, person, place, and time, whatever events leading up to the incident. And we want to reassess those things because head injuries can evolve. When we assess the spine, we're going to assess for decap BTLS. If there's impairment, we want to note the level. So pain or tenderness is a warning sign. And when assessing for spinal injuries, the patient may display paralysis. They may lose motion or they may lose sensation below the level of injury. And they may also have numbness or tingling in their extremities. And so the injury is at L1, the patient may be paraplegic, so that they could move their arms and they could breathe normally, but they would lose function and possibly sensation in their legs. If the level is at C6 or C5, then they would be a quadriplegic. If the injury is at C6 or lower, they would lose the muscles in their chest for breathing, but they would still have the nerves supplying the diaphragm, the phrenic nerves. So those originate above C6. So if it's C6 or below, you would see diaphragmatic breathing, which is the patient's chest would not move with respiration, but you would see the abdomen move because the diaphragm would be moving. And those patients are at risk for respiratory failure. If the patient's injury is above C3, they may lose their ability to breathe completely. And for patients with head injuries, for management, managing the airway is the most important thing, and it can be very difficult because we're using the spinal, using the jaw thrust. The patient may have clenched teeth, which can be difficult to maneuver, so we would need to suction around that. So we want to remove any foreign bodies. We want to address any scalp wounds. We assess for Cushing's triad, which is increased blood pressure, decreased heart rate, irregular respirations. And if we see this, then we would consider hyperventilation. That should be a medical control call, most likely. For spinal injuries, we're going to manage the C-spine. We're going to, and one person is going to be instructed to hold the head in the neutral position. If the head's not in the position, the neutral inline position, we're not going to force it. We're going to try to move it into the neutral position. If we can't, we're going to splint it in place. We're going to apply a collar. There's a finger technique. The bottom of the collar should rest on the shoulders, the top on the jaw. And this should limit the patient's motion, but still allow them to maintain an airway. Once the collar is in place, the manual stabilization is in place. We want to assess pulse, motor, and sensory in all four extremities. We will practice securing patients to a long backboard. If the patient's sitting, we can use what's called the KED, or a short backboard. If the patient's in a vehicle, we're going to rapidly extricate them. So you're not going to take time to immobilize their spine until after they're immobilized. There's a standing patient, so we're going to have sit on the stretcher now and put a collar on. And we'll end with helmet removal. So if the patient is wearing a helmet, whether it's from a motorcycle or a sports helmet, we want to leave it in place if we can. If we can immobilize the spine, if they're breathing adequately, and if it doesn't interfere with airway management. So if it's a full frontal, if there's a cage around the front of the helmet, then we're going to need to remove it. And there's a technique to do so. So it should be a two-person job, and one person is going to be at the base of the skull, and the other person is going to be on the top of the helmet towards the face, and you're going to basically seesaw the helmet off. Some sports helmets, you can just remove the face covering, and then you can leave the helmet in place. And that is the overview of neurologic injuries.